Morning, everyone. We'll get started in just about a minute. Okay, I think we'll go ahead and get started. Good morning, everyone. It's an absolute pleasure to welcome you to today's webinar titled Psychedelics in Focus: Treatment, Business, and Policy Futures. My name is Matt Eisenberg, and I'm one of your hosts and moderators, along with my colleague, Michael Darden. I'm an associate professor at the Johns Hopkins Bloomberg School of Public Health. And my work intersects the analysis of healthcare policies, economics, and their implications. So I'm really excited about today's webinar's focus. This webinar is a collaboration between the Hopkins Business of Health Initiative, or HBHI, and the Center for Mental Health and Addiction Policy, or CMAP. And this is part of HBHI's webinar series called Conversations on the Business of Health, which aims to foster an enlightening dialogue among experts and audiences on emerging topics in healthcare and grow conversation between the clinical side, the business side, and the policy side. Our discussion today, we'll be talking about the landscape of psychedelic treatments. We're going to talk about the economic contours of this industry and examine the policy frameworks that we think might shape the trajectory. Joining me, I'll turn it over to my colleague Michael to give a quick intro of himself, and then we'll introduce our panelists.
Thanks so much, Matt. So yeah, I'm Michael Darden. I'm a health economist. I'm an associate professor of economics at the Carey Business School at Johns Hopkins. I'm also affiliated with the National Bureau of Economic Research, Journal of Human Resources. I have research interests in addiction and addiction policy. And I have some consulting experience thinking about how companies structure benefits for their employees, which I think dovetails nicely with thinking about psychedelics and their treatment of mental health. So I'm just really excited to hear from the panelists today about some of the business implications for liberalization in this space. And I'll let Matt introduce our speakers.
Thanks, Michael. So our wonderful panelists today, we're super excited to have you here. We have Dr. Fred Barrett, a cognitive neuroscientist with experience in behavioral pharmacology. Fred, since 2013, has pioneered psychedelic research here at Johns Hopkins, focusing on the lasting effects of psychedelic drugs on individuals with mood and substance use disorders. His groundbreaking work, backed by the first federally funded research grant since the 1970s to focus on psychedelics effects, explores the psychological and neurological underpinnings of psilocybin. We also have Melissa Slavasani here, who is the founder and chief executive officer of the Psychedelic Medicine Coalition, or PMC. Prior to founding PMC, Melissa was the proposer of Washington, D.C.'s successful 2020 ballot initiative, 81, the Ethnogenic Plant and Fungus Policy Act. Inspired by her own experience of using plant medicines to heal her severe postpartum depression, Melissa led the Decriminalize Nature DC campaign to the largest ballot initiative victory in the history of our nation's capital. And I'll let Michael introduce our third panelist, Leah.
Yeah, we're really excited to have Leah Mix. She's the founder and CEO of Delphi, a consulting firm dedicated to the healthy growth of the psychedelic movement. They provide consulting services to both nonprofit and for-profit companies, foundations, and government bodies. She has an extensive background in consciousness leadership, education, and therapy. She's worked directly with regulators, including HHS, and leadership in the psychedelic ecosystem to help ensure psychedelics are made available safely and affordably for those who can benefit from them. And previously, she was the founder and CEO of Anthea, which works with employers to provide psychedelic solutions for mental health. So we really appreciate Leah joining us today.
Okay, let's get started. We're going to structure our conversation around a few different topic areas where we're going to have one of our experts kind of open the conversation and then have folks jump in and hopefully talk amongst ourselves. I also want to say that we're monitoring the Q&A, so please, as we go, feel free to drop questions in the Q&A and we will try to get to them as well. So Fred, I'm going to turn it over to you to start. Can you give us an overview of the current role of psychedelics in medical treatments?
Yes, thank you, Matthew and Michael and everyone for being here today and for your interest in this area. I'll start by just introducing what psychedelics are so that everybody's on the same page. When people think of psychedelic drugs or hallucinogens, you may think of changes in visual perception or visual hallucinations, or maybe very very large feelings and like ecstasy or panic and bad trips. But all of these things, while they may occur for some people, they certainly don't occur the less interesting potential effects of this range of mostly naturally occurring compounds. The word psychedelic was first coined by a British psychiatrist who is expatriated to Canada, Humphrey Osmond, who had started a clinic for patients with alcohol use disorder in Saskatchewan, and he was one of the first individuals to administer LSD in a clinical setting to patients. And he administered LSD to patients with what was at the time termed alcoholism, and claimed an incredibly remarkable treatment effect, especially for the time, of over 40% of the thousands of patients that he treated being absent in alcohol for at least a year after treatment. Humphrey Osmond had taken LSD and mescaline and psilocybin many times on his own to try to figure out what these drugs did and how they felt and how they worked, and with the idea that if he understood these drugs personally, that he'd have a better understanding of how they could be used clinically. He gave these drugs to a number of his friends, clinicians and otherwise, including the infamous Aldous Huxley, who wrote The Doors of Perception based on his experience with mescaline. And if you have not read that, I think it's a really interesting read, and I'd recommend you give it a read. So Humphrey Osmond coined this term psychedelic from the roots psyche meaning mind and delos meaning to manifest. He believed that psychedelics manifested something unique and particular about the mind that the individual didn't normally have access to during normal waking consciousness. I think that if you take that word mind manifesting at its most generous interpretation, then the coffee that I had this morning is probably psychedelic, but I don't think that's what he meant. Since then, in the early 50s and through to about 1971, tens of thousands of people were administered psychedelic drugs across the nation and around the world. Hundreds to maybe thousands of scientific papers were published, most of which do not meet modern criteria for rigor and reproducibility in science. But since about 2000, with one of the first seminal papers being published in 2006 by my mentor, Roland Griffiths, the modern era of psychedelic research has really begun to blossom, and since then we've learned a number of things. Not only can psychedelics be safe to administer to healthy, very carefully screened individuals who undergo proper preparation, monitoring, and aftercare, but also it's possible that psychedelic drugs may be incredibly helpful in treating patients with a wide range of illnesses, mostly psychiatric illnesses, but not only psychiatric illnesses. But what exactly are psychedelic drugs? Well, this big P word has right now a pretty big umbrella. And when I refer to psychedelics, I typically mean what are thought of as classic psychedelic drugs that share a molecular property of binding to and activating a particular serotonin receptor called the serotonin 2A receptor. And these drugs still span a wide range of chemical classes, including tryptamines that have a chemical structure very similar to psilocybin. I mean, to serotonin. And an example of a tryptamine is psilocybin. It's the active component in literally hundreds of species of psychoactive mushrooms. We have phenethylamines, including mescaline, which is a psychoactive component in naturally occurring in psychoactive cacti. And we also have other drugs, including ergotamines, such as lysergic acid amide, which can be found in ergot fungus, and the infamous LSD, lysergic acid diethylamide, which is a research chemical that has only been found in the lab. So those are classic psychedelic drugs, but we also have drugs like MDMA or ecstasy, which is also a research chemical that was studied in the early 80s and beyond as an augmentation to psychotherapy, in particular couples therapy, that had been scheduled as a controlled substance, but more recently studied for the treatment of PTSD. MDMA is thought by many to be a psychedelic drug, and then there are other drugs that is, when you get further and further away from serotonin activity, you get further and further away from a classic psychedelic. Ketamine is considered a psychedelic drug by some, but it has a lot of properties that are not similar to other psychedelics. People can go as far as thinking that cannabinoids, like THC or constituents of cannabis, are psychedelic. All of these are different drugs. I want to make it clear that all of these are different drugs with different risk profiles, different potential benefits, different therapeutic models that are built up around them. And it's important to note those differences when talking about psychedelics. Okay, so now that that's out of the way, I want to focus in on two drugs just as a very brief overview. One is MDMA, and MDMA has been studied now extensively for the treatment of post-traumatic stress disorder, and MDMA is now, I suppose, the compound with the greatest amount of evidence in terms of a beneficial, potentially therapeutic effect in treating mental health disorders, and it is now probably the closest to evaluation for approval as a medicine in the United States by the FDA and possibly the EMA soon. And the next closest drug, the next drug with the most evidence behind it is psilocybin, which I mentioned is the active component in many forms of mushroom, and that's the drug that we primarily study here at the Johns Hopkins Center for Psychedelic and Consciousness Research. Whereas MDMA has been primarily studied for PTSD, psilocybin has been primarily studied for the treatment of various forms of mood disorders and substance use disorders. And psilocybin is now also being studied for a much wider range of indications, including obsessive compulsive disorder, post-treatment Lyme disease syndrome, Alzheimer's dementia, opioid use disorder, cannabis use disorder, headache disorders, and the list goes on. What I want to make clear from this point is that to date, none of these compounds yet have any approval as medicine in the United States or nearly any place in the world, and we still have a long way to go. The FDA typically, when approving a drug as a medicine for treatment of anything, typically requires a substantial amount of evidence for both the risks and the benefits of the compound in a particular use case. And while a number of studies have gotten a lot of press, at least for psilocybin recently, we still have a number of steps ahead of us before we can begin to evaluate whether psilocybin can be approved as a medicine. But one more thing to kind of point out, like wait, so what is this? Do you give someone the drug, they go home, and then they're cured? No, that's definitely not what it is. Psilocybin therapy itself and MDMA therapy follow a bit of a similar time course and structure. And let me just, if you will, share one screen, which I think will illustrate in a way what goes on and what we mean when we talk about this therapy. So psilocybin therapy is called by many psilocybin assisted therapy. So it's not just a drug effect. When we are administering psychedelic drugs, can everybody see this? Yeah, okay, thank you. So when considering a participant for a clinical trial with psilocybin or MDMA, participants undergo careful screening. Psilocybin specifically has very, very few physiological risks. It's known to increase heart rate and blood pressure to a modest degree. This is time limited to about the 4 or 6 hours that people experience some kind of a subjective effect, the trip, if you will. So we exclude people with some kind of cardiovascular risk. The main risks of psilocybin after this are mostly psychological. People can go through incredibly powerful emotional and personally relevant experiences. Sometimes people say they've had the most challenging experience of their entire lives. It can be harrowing. It can be very difficult to get through these experiences, but that doesn't mean they're not therapeutic. Sometimes those difficult, challenging experiences are the therapy, they are the medicine. But we do carefully screen out people who have a personal or family history of psychosis or mania with bipolar disorder. We believe there's reason to think that these drugs may not be psychologically safe entirely for people who have that vulnerability. But these are just two of the main exclusionary criteria. There are other risks that we try to screen for. But briefly, just to say, once we've carefully screened an individual and identified them as someone for whom we think it may be safe to administer these drugs, we then go through many hours of careful preparation and psychotherapy. So after screening, we go through typically 6 to 8 hours of psychotherapy in studies of patient populations. That's followed by 1 or 2 or possibly 3 drug administration sessions where a participant comes in, and after one final screening, we administer a compound, and then 2 trained therapists will sit with the individual throughout the day while they go through the entire time course of drug experience. And it's not just a drug experience. With psilocybin, often people are directed to turn inward and just attend to whatever arises in consciousness. With MDMA, people are asked to actively engage in some form of psychotherapy. And that's not where it ends. If anything, that's just the beginning. People have these experiences, and then it is important to carefully follow up with weeks to months of aftercare and follow-up therapy so that people can begin to understand and help to figure out what they experienced and how that fits into their life and what it means for them going forward. So when we say psilocybin assisted therapy, MDMA assisted therapy, psychedelic assisted therapy, it generally follows this framework. And it's important to note that this is not just a drug in, healing out experience. It is very important, very careful kind of interaction between the drug experience and a psychotherapeutic experience. I think those are the points that I really wanted to make sure I got across.
This is so helpful, Fred, to the audience to understand how these work. You know what? I'll turn to Michael now to get an overview of the business side, and then I'll have more follow-up questions for you in a bit, Fred.
Yeah, thanks, Fred. That was a great introduction, really helpful for everyone. Yeah, so I mean, I guess with the liberalization of psychedelics, obviously there are going to be opportunities for private actors to explore this space, and that's going to include for-profit and nonprofit organizations. So Fred already talked about the fact that obviously there are regulatory challenges for those businesses, but they already exist, and so I'm kind of excited to learn about the growth potential, like how one of these firms is started, where is their innovation possibilities, where how does finance work, what about safety, what about public perceptions, and all these things. So I'm gonna turn to Leah, and Leah, it'd be great if you could just give us a sense of the current landscape in the business of psychedelics.
Yeah, thanks so much, Michael. So these are really critical questions in terms of how are these medicines actually going to eventually reach patients, right? And how is this going to grow and scale in a way that is going to be a viable industry and as smoothly as possible? One of the things that I think is really critical at this juncture is that we have frameworks to talk about psychedelics and the scaling of psychedelics because it is such a highly complex landscape. So a very basic framework that we want to start with for the conversation is that the spectrum of access for these medicines legally has 3 access wedges. We can think of it as medicalization, legalization, like what's happening at the state level with Oregon and Colorado, and then religious use. So for the purposes of this conversation, we're really focused on that medicalization wedge, medicines that are moving through the FDA, treatments that are going to be received in the medical system, and also noting that there's going to be interplay between all 3 access wedges. But when you're having a conversation about psychedelics or psychedelic business, you want to understand in which of those access wedges the organization or the individual is sitting, because each of them have different regulatory requirements and different revenue streams that are going to be coming towards them and so forth. So that's a basic concept for us to work with. Now, what we see currently is that there's about 6 different kind of segments of this industry, the largest being biotech. So there's about 50 different biotechs, and there's about 50 different drugs that are actually going through the FDA in phase 1, 2, or 3. The next is clinics. So start the burgeoning infrastructure, and we really need to focus on this, the care delivery infrastructure, which right now is mostly ketamine clinics, which is about 400 ketamine clinics in the US, and then training programs. So there are a number of training programs that are both academically based and private companies that have sprung up to meet the incredible demand and need for therapists to be trained and ready to deliver this care. So right now there are, we count 5 graduate programs that are academically based. There are about 70 programs that are oriented towards people who want to become psychedelic therapists. About 40 of those are offering certificates. And then there is over 250, as far as we can keep track of, it's growing every day, just general courses for people who might not even want to deliver care, but they have an interest in psychedelics. So training and offering trainings, that is actually a business segment that will continue to grow. Then there is a tech component. One of the interesting things about the tech component in this space is we tend to see it coupled inside of like a clinic play like Osmind or Wonder Science, or inside of drug development, not standalone. An exception to that would be like Journey Clinical. And then I am aware of 3 different companies that are working on healthcare benefits. So actually bridging in to the payer community in order for that reimbursement to flow, which is really the linchpin to this all working. And then, of course, there are a whole constellation of nonprofits. This spans everything from drug development under MAPS and USONA to organizations that are addressing harm reduction, such as Fireside. Now, the industry has been able to take in about 3.6 billion in investment thus far, and that's primarily been VC funding and angel funding, philanthropy, and a very small amount of government funding. The projection is this industry will grow to about 13 billion by 2031, and all of the ROI that happens is, of course, going to be tied to reimbursement. And so it's really important when we look at the medical sector, how that's going to grow, how that's going to scale, that we understand how that reimbursement is going to work. And therein lies the greatest uncertainty. There is a very simple way to think about this. In order for anyone in this sector really to make ROI, unless the money is coming directly from the government, is for drugs to go from the manufacturer and the drug developers and reach patients, right? That is what needs to happen. Now, in a basic pharma play, it's actually pretty straightforward. There's drug development, drug manufacturing, then it enters on a formulary, a patient is prescribed by a doctor the medicine, they get the medicine, and then reimbursement flows from there, right? That is the framework that many institutional investors and others are looking at this with. But as Fred pointed out, it's not that simple. So that care delivery segment that sits in between the drug going from the manufacturer to the patient with psychedelic assisted therapy is much more complex. And so as an industry, that is where we need to really be focusing in understanding the different scenarios of what that care delivery system might need to look like based on the research, and what needs to happen in order for that not to create obstacles, bottlenecks, and so forth for those drugs to reach patients. So I think that, just having some basic framework and understanding that there is also going to be a natural tension between the quantity of the therapy component and the unit price for the drug. There's a certain dollar amount that the market is going to bear, right? And so the thinking can go to, well, if we had less therapy, then we can have a higher unit price, and certain segments, certain players will make more ROI. When we also look at that, we know that that is tied to access as well. So less therapy might mean greater access, but we want to be really, really careful in that conversation is the one that we're following the research and that we're not getting into a situation where driving a higher unit price is actually jeopardizing patient safety, right? Because that is the greater risk that in post-market surveillance, we will start to see adverse outcomes, and then we're working in the other direction. So just wanted to lay out some critical pieces here. We definitely need to see the scaling up of that care delivery piece in terms of who will be the practitioners who are able to deliver the care, what are going to be the training requirements. Of course, all of this is going to be affected by things like the REMS. So a lot of scenario planning is actually going to be necessary. So I'll stop there.
Thanks so much. No, that was great. I think it actually dovetails nicely into this idea of like policy is going to be changing. And so maybe or the policy needs to change, and so much of the business aspect of this is going to depend on how the policy evolves. So maybe I'll ask Matt to move on and chat with Melissa for a minute.
Yeah, I'm gonna ask Melissa to give us an overview of this, but I also want to say there's so many great questions coming in the chat. Keep them coming, and we will get to them shortly and ask our panelists these great questions. But Melissa, I'll start. Can you just give us a map of the current landscape of policy activity here? Are there hot spots, cold fronts? What's going on?
Yeah, well, the policy landscape is just as complicated as the business and the science landscape of psychedelics. So the issue of psychedelics becoming a legitimate medicine in the US, I think our federal government is really thinking very carefully about how this moves forward. And I got my start in the psychedelic space at a hyper local ballot initiative. So in that, I think the initial advocacy in the psychedelic ecosystem was really following in the footsteps of cannabis reform, in that local jurisdictions were starting to decriminalize mostly natural psychedelics. I feel like the branding of these ballot initiatives being under natural psychedelics is a bit more palatable than a city or a county decriminalizing LSD and MDMA. So a lot of the decriminalization measures have been really focused on natural psychedelics and at a hyper local level. Once I got my campaign through to the finish line, I realized that we can't follow in the footsteps of cannabis reform. This issue is far more complex than cannabis because you have real legitimate healthcare needs and issues that need to be addressed. And while there was an element of cannabis reform that was medicalization, it became clear that that was a stepping stone to recreational use opening up. So with psychedelics, it's a bit different, and when we elevated this conversation to Congress, we saw that members of Congress were really frustrated that there wasn't a lot of thought put into medical programs for cannabis. So with psychedelics and ensuring that we don't kind of fall into the same pitfalls as the cannabis reform movement has, we need to, give it the medicalization of psychedelics, make that as legitimate as it can possibly be. I recognized really early on that, while decrim was happening in cities all over the country, and then legalization of adult use was started to pick up at the same time in states like Oregon and Colorado, We needed to ensure that the federal government is moving in lockstep with state and city level reforms. Now, that doesn't look the same as what's happening at city and state level. We're not really discussing decriminalization or even legalization at a federal level. What we are discussing is how we can get federal dollars to flow into the science and research of this. And in doing that, we are creating legitimacy in this space and ensuring that safety is a top priority. Safety is a major concern for members of Congress. So we have to follow the science in this. So the work that's happening at state levels is really focusing on adult use programs, which are not medical programs. Very few, if medical practices cannot happen in these state programs. These are just access programs, which does create a problem with people who are seeking out psychedelics for healthcare reasons, but their only access point is through an adult use program. That's another discussion, but with the federal government, it's really getting them to see the research that currently exists and how an influx of federal dollars can really flush out some of the issues that need to be flushed out. And it gives the federal government a seat at the table in a way that they weren't at the table with the cannabis reform movement, which ultimately made that movement extremely politicized. The goal of my organization, Psychedelic Medicine Coalition, is to keep this issue as apolitical as possible, keep it focused on the science, keep it focused on the research, keep it focused on the goal of creating safe, affordable access for people. And all that is involved with safe, affordable access, meaning, insurance coverage and, approval of these medicines. So what we have is at the FDA is multiple psychedelics in the clinical trial process. Just this week, MDMA, the sponsor for the MDMA had applied for their new drug application. It's a major milestone. They're anticipating approval late 2024 for that, for PTSD. Again, like Leah said, we're still waiting on what the REMS will look like with that and how restrictive the use of MDMA is. Will it be like ketamine in that ketamine is an approved anesthetic, but it's now being used for treating mental health issues, prescribed off label, and people pay out of pocket for that. We don't know if MDMA will be a similar situation, or will only a PTSD diagnosis be the only access point for MDMA assisted therapy. It's yet to be seen, but the FDA is treading in brand new waters here with this. So, I think that the FDA is a major player in this, and that they're going to have to be adaptable to this new realm of medications that are just so completely complex and different than previous medicines that have been approved before. So the FDA is playing a role in this, and then Congress is playing a role, and the conversation lately with Congress the last few years has really been centered around veteran health care. There is a complete and total crisis within the VA. We have up to 44 veterans taking their lives every single day. That statistic itself is very hotly contested, but it is, you talk to anybody in the veteran community, and this is a true crisis, and the VA has been ill-equipped in dealing with this issue. So where we're working right now is mostly on the conservative side of politics, and really getting them to understand that psychedelic assisted care can be a really effective and credible use of our time in treating veterans. So just this year, there was $10 million passed for clinical research in psychedelics within the Department of Defense's budget. That is a very major milestone for the psychedelic ecosystem. This would be the first time that Congress has really allocated funding for this. And then next year, we're going to have a really big push for funding. We want to try to nail down $100 million to $150 million in federal research funding for these medicines, and not just focus on the veteran community. I think we've gotten so much amazing support within the conservative side of the political spectrum within Congress for veteran healthcare, but the challenge is going to be broadening that to address the mental health concerns and the addiction crisis that's in this country. I think, and that can really span through Republican and Democrat offices, in that every single member of Congress understands we are in a mental health crisis. We aren't sure what to do about it. We are in an opioid addiction crisis. The current solutions aren't working. They're hearing this from their constituents, and they feel a bit of pressure to make a move. I think that some of them are a little concerned that, psychedelics is a bit out there for them politically, but honestly, if we're focusing on the science and research side of this is a much easier argument to have, knowing that, rescheduling is the really big issue that needs to be addressed. However, while I explained before, cannabis and psychedelics are really different topics of discussion within the halls of Congress. In many offices' eyes, the rescheduling of psychedelics is necessary. However, they're not going to jump over cannabis rescheduling to reschedule psychedelics. So, and that's a political move. So we're all waiting with bated breath to see what happens with cannabis rescheduling. And as soon as MDMA is approved and then psilocybin progresses through clinical trial with the FDA, and then cannabis scheduling happens, we can have really meaningful conversations about psychedelic rescheduling. So, this is going to be a long process. Our federal government doesn't do anything quickly, but as long as as long as Congress and the administration are moving forward, no matter how slow it is, I think that we will have really meaningful change with psychedelic assisted care within the next 5 to 10 years, and that's in my mind pretty quick for the federal government. So, I think that there's a lot of promise here, and it's really on the advocates to keep this based on science and fact, and not allow this issue to become political, because it is so incredibly important for so many people who are suffering with no solutions to their issues. So it's an exciting time to be on the Hill talking about psychedelic drugs, and I see a lot of promise in the future.
Melissa, that is so helpful, and I so appreciate you laying out the similarities and differences with the experience with cannabis, because I think, that comes to a lot of folks' minds, and there are a lot of differences there. So I appreciate you taking some time to lay that out. Maybe we'll start going for some of the questions in the chat. There's so many great ones here. Just to start, Fred, there was one question here about a musician diagnosed with dystonia talking about microdosing psilocybin. I hear a lot in the news around microdosing, so I wonder if you could comment on that, and then comment on psychedelics treatment for dystonia. The second part of their question is also, I think, important. Are there risks of addiction when it comes to psychedelics, and how does that play into it?
These are some really great questions, and I want to just start by making incredibly clear that I in no way, shape, or form are trying to minimize or dispute an individual's personal experience. But in saying that, there is no empirical evidence for any benefit of microdosing at the moment. Caveats abound, including but not limited to the fact that when people are microdosing in the world, it's not always exactly clear that everybody who says they're microdosing is doing the same thing. Some people who say they're microdosing are taking doses that they say have no acute effects at all. You don't feel it. Other people take microdoses that are not macro doses, right? So it's a microdose that has a subjective effect that yet doesn't impede your kind of functioning in the world. So it's a little unclear out in the world what microdosing means, but in the lab, the few studies that have been conducted with carefully controlled drug administration have really only studied a microdose, which is not microdosing, right? People who microdose say they take, a microdose every couple days for 6 to 8 weeks or something like that. And so, frankly, that hasn't really been rigorously studied in the lab. And microdosing has not been studied in the lab in any patient population of any sort. So the data we have suggests that nothing's happening, but the data that we have are not satisfying. So within that context, yes, there's nothing known about microdosing or macrodosing in dystonia, but it's a very interesting question because, there is, in a former academic life, I studied music cognition and music perception and the neuroscience behind that. And there's actually a lot of 2A receptor expression along the primary auditory pathway from the cochlear nerve to basic auditory cortex. And so there are reasons to think that psychedelics may push around auditory perception, and especially in macrodosing studies, there's replete with claims and patient reports that their perception and understanding and experience of music really changes. So there's a lot to learn there. With regard to addiction, I also want to be clear that there are people in the world who meet criteria for substance use disorder as applied to psychedelics or hallucinogens. That being said, psychedelics really don't show up as typical drugs that are misused. And what does that mean? Well, when we say that someone has a substance use disorder, that typically looks like a person who is repeatedly self-administering, doses of a psychoactive compound that lead to changes in their ability to function in the world, and they repeatedly seek out and self-administer this compound or drug, even with the knowledge that they're suffering because of it ultimately, and that it's impairing their functioning or impeding their ability to really lead a productive life. A little more specifically, we have lots of different assays or measures to see if a drug has what people call abuse liability, even though that A word is a little contentious. With animal studies of drugs, if a drug is something that you can train an animal to repeatedly self-administer, that's a sign of potential abuse liability. If if you train an animal to self-administer one drug and then you introduce another drug and it behaves the same way, that's called substitution. One drug substitutes for another. That's another measure of abuse liability. Psychedelics, really, you have to trick animals. You have to bend over backwards to trick animals to self-administer psychedelic drugs, and they don't substitute for any known drugs of misuse, if you will. Also, patients who are suffering from substance use disorders often get some kind of craving and withdrawal syndromes that then lead to feeding and maintaining this repetitive self-administration. There's no known craving or withdrawal syndrome that arises from the use of psychedelics. And in fact, especially with macrodosing psychedelics, people, especially with powerful experiences, will really not want to repeat that anytime soon. They can be powerful, they can be life-changing in a positive way, and they're something that people don't want to do every day. I could go on and on. Basically, classic psychedelics don't typically show up in the same way that other drugs of misuse do.
I'd like to follow up with a question from the chat that I think follows with Fred's great description at the beginning about how many different substances really kind of fall under the psychedelic umbrella. And this is a question for Leah. It could be the case, is from the chat. So it could be the case that like some of these compounds work really well in like an old school kind of pharmaceutical industry framework or drug to patients, but others might need, more drug plus non-drug treatment, or as you described earlier, a variety of different kind of delivery ideas. So can you maybe like partition the business landscape for us a little bit in terms of which of these compounds do well in the framework that you were describing, and which might need more elaborate kind of treatment?
Thanks. It's a great question. And I think what's very important here is that we follow the science. It is aspirational to believe that these compounds at some point, even with second gen development, drug development with psychedelics that might have less psychedelic effects, et cetera, may need less to no therapeutic support. We're not there yet. And so what can happen with this conversation is what is aspirational and way down the road can start to influence what people believe is possible right in the current moment, and starts to skew priorities. So I just wanted to say that I hope for the day when these compounds are shown to be efficacious for not just mental health conditions, but for chronic medical conditions. So I would say just Fred could probably go much deeper into this than I could from a scientific perspective, but on the surface of it, conditions that are serious mental health conditions, we would generally, I think, believe that therapeutic support is appropriate. And this is true with even SSRIs today. It's found that they work better with a drug therapy combination. So we would want, someone is very vulnerable, they have trauma, they have serious depression, et cetera. That therapeutic component for those mental health conditions, I think, is going to continue to show to be essential for a while. As we move into more specific and medical indications, we may see less therapeutic support being necessary. But again, this is going to be, we have to focus on what does the research tell us at this juncture. And but the point of the question is well taken. And yes, we do hope that these turn out to be curative and helpful very, very broadly.
So interesting, Leah, and I think like a lot of these questions do a really nice job dovetailing on one another. Melissa, there's a question from a volunteer mental health advocate, an engagement specialist. Can you talk a little bit about community engagement tools you might recommend that might increase understanding of psychedelic assisted therapies if the goal is to drive policy change? Are there nonprofit resources focused on public engagement here?
Yeah, I mean, there's a whole slew of nonprofits that have been created out of the psychedelic ecosystem, all focused on various areas. Public engagement is really critical to at least the policy side piece of this. Um, a lot of policy change is, yes, driven by advocates going to Congress and having meaningful conversations and bringing stakeholders, but also that public engagement piece is really critical in getting members of Congress's constituents activated on an issue and getting them to really push them to to push the policies that they are interested in seeking. So there are various nonprofits that have training programs, and not just for clinicians, but anyone who just wants to get a background on what's going on, what psychedelics are, like an overview, a general overview of what psychedelics are and what's happening in the landscape. Vital is one program that's Psychedelics Today. It is a training program, but they also are a media company that has a really amazing podcast that brings guests on to educate viewers who want to learn more. There's also the Psychedelic Medicine Association that's training healthcare workers. There's obviously my organization, Psychedelic Medicine Coalition, and we have a sister organization called Psychedelic Medicine Advocacy that will be engaging in public education and intentional media campaigns to really support the work that we're doing on the Hill. So there's a few outlets out there. Obviously, there's a litany of conferences that the public can attend. The most recent one was Psychedelic Science in 2023. That was in Denver in June of this year. My organization will be holding a policy conference in May of 2024 that would be open to the public. Not going to be as large as some of the other conferences, but very, very focused on bringing together key stakeholders and on the DC side, like FDA officials, DEA officials, members of Congress, appointed officials from our administration, bringing them together, and let's really forge a pathway forward for psychedelics, and what does this policy landscape look like, and what are the hangups, and what do we need to overcome. So bridging the policy with the science and research side is really, really important, because like I said before, that the medicalization of psychedelics is really where the federal government is going to reside in. And we want to ensure the public understands that that's not you know, the medicalization is just one piece of it. But this is where we can start to initiate a cultural change within the halls of government around psychedelics, and where we make government officials really comfortable around this issue. So there are multiple angles into this, and it's just whatever you want to focus on. If it's the policy side, you know, you can always sign up for our newsletter and get the latest and greatest of what's going on with Congress and the president's office on this issue. But there's really wonderful resources out there for the public who have their interest peaked in psychedelics.
One very short question, Melissa. Someone
Mhm.
asked, can Johns Hopkins students attend the conference your organization is putting on in May
Yes,
24?
yes, of course, anybody can. Yeah.
Anybody can.
I have a question that can be for all of the panelists or any of them. I mean, you know, Melissa talked a little bit about the parallels or lack of parallels with the cannabis, you know, wave of liberalization over the last 30 years. And one of the things that's really changed with cannabis is just that the public perception has evolved enormously, right? And so I'm curious about public perceptions and attitudes surrounding psychedelics as they scale with liberalization on the regulatory side. You know, there are clear medical benefits with respect to mental health, thanks to the work that Fred and others are doing. But how is the conversation going to change when there are adverse events, when there are public, high-profile kind of adverse events? As these things scale, you know, there's bound to be something that happens that gets some national attention. And what are some strategies to kind of think about how to respond to that?
I mean, personally, I think we need to be talking about these adverse events much more. I think we need to be talking about the harms much more. We need to own every single piece of psychedelic assisted care. And when I was starting my organization, I got a lot of criticism for having psychedelics in the name of my organization. And, you know, people are not going to like that. Members of Congress aren't going to take meetings with you. And we just found that it's not true. We are taking this word psychedelic, it was kind of burdened with the propaganda from the war on drugs, and people heard the word psychedelic and immediately thought of the 60s and just like rampant use of psychedelics recreationally. But in a way, we have to own that piece of that part of psychedelics that we want to repress and we don't want to talk about. But if we put it out there and say, yes, these are the risks, I think that gives us far more credibility when we are speaking to lawmakers and the public, because it's showing a level of maturity that maybe the cannabis reform movement didn't have. I think their first instinct was to repress all the bad stuff and let everyone think that this is really amazing because it was so critical to get this to the finish line. And my point is, this is critical to get to the finish line, and we're going to do that by being really open and honest about what this is and what this isn't.
I just want to echo that and amplify that. I think it really comes down to public education. I spent some time a minute ago explaining how psychedelics don't really show up as drugs of misuse, but that is not in any way to say that they are not powerful psychoactive substances with clear and defined risks. And I have to admit personally, my own personal views that don't reflect any organization that I work for or any individual who I commiserate with. I know that we have a regime of criminalization in this country, and I think that has failed, and I think it does more harm than good. And I don't think that criminalization of these compounds is the answer, but I admit that I don't know what the answer is. I think ultimately it's a question of harm reduction through education. The risks that I think are being opened up by legalization movements in different, you know, localities and states in the country right now are going to assure that some of those risks, you know, turn into harm, and I think that the harm is going to happen. The differential between how we as a society respond to what will be high profile events of harm related high profile events is really it's based on how well we're able to educate not only policymakers, not only healthcare providers, not only lawmakers, but the general public. I think we will have succeeded. I don't think that harm will be a success, but in the eventuality that harm occurs, I think a success will be that people understand it for what it is, and that people don't say, "Oh my God, this is terrible. Of course, see, I told you so. We shouldn't have gone down this road at all." They can say, "That is tragic and it shouldn't have happened, and we need to make sure we understand how to prevent it in the future." But also, that shouldn't detract from the real medical advances that we're making with these approaches.
I have to echo what Melissa and Fred have said, and this is a tremendously critical conversation as we try to move these medicines into the general public. So it's a matter of education. So the general public, the medical system, and also other systems. So first responders, for example, right? All of these things will weigh into if we're going to see how many adverse outcomes we're going to see. What we believe is that there will be, I mean, without a doubt, there's going to be adverse outcomes. And also, we believe that this is going to be a net positive, right? So it's like a new form of surgery in some ways, that not everyone is going to have the best outcomes of surgery, right? But it's important that it exists. One thing that I think we can really look at is what is happening with the institutions of the government. So the FDA has overcome a tremendous amount of stigma, right? And around psychedelics over these years in order to look at what are the benefits, what are the possible harms, because that's their job, but what are the possible benefits? And I think it definitely helped that this was brought to them by a nonprofit first and foremost, so that they could have this discussion that's based in science. We see this now with the DoD, and what we really need is for other institutions to take the lead and see what the FDA is doing, take their lead in terms of understanding the risks, educating themselves, educating the organizations, the people, the professionals that are under their jurisdiction or their umbrella, both to the risks and to the benefits. And of course, we're going to see the quality of post-market surveillance. We're going to be keenly interested in that data. And if we can see correlation between different types of therapeutic support or harm reduction, or the kind of training that's happened, such with the Denver Police Department, right? The kind of training or support that an individual has in their community, and is that correlated with adverse outcomes? So that's my piece.
Thanks, Leah. Fred, I saw you had your hand up before. Do you want to jump in?
Yeah, sorry. I just felt the need to clarify that the risks I was referring to are primarily risks in uncontrolled settings without proper preparation and support. And there are risks that we feel that we can well mitigate for properly screened individuals in a controlled setting when these therapies are administered by trained professionals. Not to say that there aren't risks, but just to put a little more kind of bumpers on those risks. Yeah.
That really emphasizes what Leah was talking about earlier too, with the importance of education and the training of the workforce that are going to administer these drugs, right? So training is so important, and this is a very important kind of labor economic topic. Like how do we get these professionals to the market?
Yeah, just in the last minute here, I wanted to mention that we have created just some reference materials and so forth for people to access, because we're talking about a lot of stats and things like that. So I was unable to put it into the chat, but it's at Delphi-Circle/JHU, Delphi-Circle.com. I think I need to put it in the chat, but I'm unable to do that. Tech, so people can find those resources there.
I just took a look, Leah. It is indeed Delphi-Circle.com. delphi.com/JHU, a wonderful set of resources you've put together here at delphi-circle.com/JHU. Oh no, now it is in the chat. Oh, great. Thanks.
Just put it there.
Fiona. Wonderful.
welcome.
Thank you. We're now at the time, and I don't want to keep everyone longer, but I just want to say thank you so much to all three of our panelists for engaging in this discussion. We can see by the Q&A coming in, I think folks found this incredibly informative. We could have a 5-hour webinar on it. We so appreciate your time. Michael, any other closing thoughts?
I just want to thank everyone as well. This was really informative and I enjoyed it quite a bit. So thanks to all three of you.
Thank you all.
Thank you so much.
Thank you.